What is rehab or rehabilitation? My name is Fred Vigueras, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab podcast. As a direct care practice owner, I see people with insurance, some people without insurance, some people with a very high deductible. It really ranges. I think one of the common misconceptions I'll address is that the people that I see are very well-to-do and they are looking for kind of a concierge feel with their medical care, but that's just not really true. The patients that I've been seeing really come from a fairly wide and diverse background, and I wanted to share this particular story of a patient I had recently and some of the issues that kind of popped up as a result. And so I had a young boy, probably 10, turning 11 years old. I came in I was called by the mother with a history of hip pain. And hip pain in that 9 to 10-year-old range can be from a constellation of things, but this was not related to a particular injury, just slowly progressive hip pain. And so I brought them in. I saw that the boy was hobbling and was in a pretty good amount of pain. And so in my practice, I use predominantly ultrasound. I don't have x-rays because for certain reasons, I just rely particularly on ultrasound. And the hip examination was positive for hip pain, no focal motor or sensory deficits. Fairly healthy kid, just anytime you move the hip, it hurt. Very difficult for them to get around. And so under ultrasound, I can see certain tissues. I didn't see any evidence of a bursitis, no obvious muscle tear, but I could see a small effusion of the hip joint. And that is a little bit of a clue that something is actually going on. I was able to compare the right hip to the symptomatic left hip and could see that there was clearly a difference in the amount of fluid inside of the hip joint. I get a little bit of a peek of the anatomy. I didn't see anything obvious in terms of the shape of the hip, but essentially with the atraumatic hip picture, the differential from my standpoint can range from having a slip capital femoral epiphysis, that's the top of the list, where you have essentially almost a slight subluxation of the bone/growth plate interface, which can certainly cause pain, leg calf Perth's disease, and also transient synovitis. Now, it's very difficult to tell that there's a difference it's very difficult to differentiate between these various conditions without advanced imaging. But the fact that the ultrasound could clearly see that there was an effusion within the hip joint should always kind of raise a flag. I guess maybe I should back up. Anytime you see atraumatic hip pain in a young child, that should always raise a red flag, because children, they tend to run and walk through pretty much anything. So if something slows them down, I almost always will pay attention to it. So the next step from there was we need to get better imaging, get an x-ray, potentially advanced imaging, like an MRI, to see is there any evidence of bony edema. But not to go too far too fast, I thought to myself, probably the best thing in this particular case is to have this particular patient see a pediatric orthopedist, just to be safe. On the whole, there are certain conditions that you don't want to miss, and having a SCFE or slip capital femoral epiphysitis is one of those conditions that you do not want to miss. In my practice, I enjoy collaboration. I like talking with other docs to essentially not just deliver a better healthcare package, but also it just makes the whole process smoother. There's less holes. The care is generally better. Now, it is definitely challenging because in my network of physicians, a large majority of them are insurance based, so they have a very high volume clinic. There are some direct care orthopedists, but none of them are in my area. So the first thing was I called up the pediatric orthopedist office. I spoke with the front desk staff. Of course, I had to get through the automations, but I finally got through. And I told the staff there that I identified as a physician. And I said, I have someone who I think may have a SCFE, and I would like them to be seen. And I do that intentionally because sometimes with medical offices, it is easier to get someone in if you have a direct doc to doc, or if you have a physician calling personally to advocate for their patient to be seen. Sometimes you can sneak someone in if it's an urgent or emergent issue. So again, I thought it would be a good idea to just say, hey, this is a doc calling for another doc to see if they can do them a solid, get this one in. And so I was placed on hold, and they said, let me see if we can get them in. And at this point, I'm thinking, even if they were able to see somebody, they can at least do a formal examination. They can get x-rays within their system. Sometimes that's a challenge because if I did x-rays outside of their system, they may not be able to see the x-rays. And again, it can slow down the process, or they may have to repeat the x-rays in their clinic, and that delivers more radiation to the child. Nobody wants that. So again, I'm thinking, how can I save time, money, and be efficient at the same time? The staff comes back onto the phone and says, just send them to the emergency room. And I said, this isn't actually an emergency, but could they, even if there's a physician assistant, nurse practitioner, somebody, I just want to connect this particular patient to your clinic to make sure that there's a specific handoff. Because what is the outcome of going to the emergency room? It ends up being like a 2 to 3 hour visit. It's an x-ray, all to see an orthopedist there that is ultimately going to say, this isn't an emergency, but I will follow up with you in the clinic. And so I explained my cases like, I can send over my note. I do see there is an effusion. Even if there's more imaging that needs to be done, I'm more than happy to help facilitate this. But essentially, is there anybody that can see them in the outpatient clinic? And aside from the efficiency aspect of things, I am trying to make this cost effective for this particular patient and their mother. They do have insurance, but they have a very high deductible. So I'm trying to be mindful of that and not just the care part of things, because you go to the emergency room, they take your blood pressure, they take your temperature, you accept a sandwich, all of that is billable. The simple x-ray should be like maybe $100, but you get an x-ray in a hospital system, it's like $1,000. I'm just throwing out random numbers. I think you guys get the point. It ends up being some crazy costs, and then you get consulted in the ER. The emergency room physician, they consult an orthopedist. These again are just tacking on the bill. So again, I pleaded my case, and essentially they said, just send them to the ER. And I could not get a better answer than that. So I said, I left my name, my number, and I said, can you please just pass this message along? Long story short, I never got a call back. I wasn't about to send them to the ER because it's unproductive. But it got me thinking, I was like, why would they send me there? Or why would they send their patients there? And my guess is that's where the orthopedist is. Perhaps their clinic that day was the OR day, and so they had no surgeons in clinic. And so they were thinking maybe if the patient was seen in the emergency room, the on-call orthopedist will be able to see them. Playing devil's advocate, the pediatric orthopedist side of things, maybe that was the best solution in that they could give me to get the patient the care that they needed to be seen by an orthopedist, was to go to the place where the orthopedist for that particular day was scheduled, which is their on-call in the hospital. And even in that situation, that just seems like the worst, most expensive solution is, let's send the patient to the ER to wait for a long period of time to get tested in the most expensive place, only to be told to follow up in an outpatient clinic on a separate day. In some shape or form, I think I might have just elected to, okay, is there another day this week that they can be seen? That would have been a lot more efficient, because outside of the pain control, which I can manage, there isn't anything emergent that needs to happen. As long as it's addressed in a timely manner and there being things like that, there wasn't anything necessarily emergent. And I explained that to the staff. I said, this is not an emergency. This is inappropriate. But this was the only answer. This was the only solution that they could give me. And it got me thinking, I was like, what would the alternative be? In my particular case, what I ended up doing was I ended up ordering the x-rays at the hospital system because I don't have my own x-ray machine. So it ended up being a little bit more expensive than it ordinarily would have been. I've seen an x-ray for $100. They charge $250. It's fine. And I was able to read the x-rays myself. I was able to get the radiologist to get the reports. So there was a little bit more supporting evidence that, okay, there's no obvious orthopedic deformity. There was nothing that says, hey, this is something that needs advanced imaging or emergent surgery, which is great. I ended up continuing to follow the patient moving forward, monitoring their symptoms, writing them an excuse note from school, things like that. And I was completely fine. And I know that I had that ability in the very beginning, but I thought I'm being conservative, just trying to do the best for my patient. And even in my own personal efforts, I could not get them to see a pediatric orthopedist. And then just to me, I was just like, that's just a shame. It's just a shame that the only option is the most expensive, inefficient option. And that's really what my practice and my mission is about. There needs to be a different pathway, that folks need to go through, because having insurance, while it feels good, depending on your plan, it still might be the most expensive option. Again, this is the population I'm seeing is they have high deductibles. Now, in terms of the overall solutions, the only thing I can really think of right now is to try and do what I used to do in the past, which is essentially educate and mentor future medical students about different models of care. And I'm talking about direct care in particular. Traditionally, specialty care, especially orthopedic surgery, is done in a insurance-based setting, but there are people out there who are now doing orthopedic surgery at a flat rate. There is transparent pricing, such as my practice. I have transparent pricing, so everybody knows what the bill is going to be. There's no surprises. The consumer can certainly do their due diligence, price shop, and also do research on the physicians that they'll be seeing. And so unfortunately, the way that the healthcare system is right now, I never say that it's broken. It's designed exactly what it is to do, which is to bill and collect money. That is 100% what the system has been designed to do. And so in my mission to try and find different pathways to care for the people in my community, and maybe I just stumbled across a particular solution, which is maybe we need to be using ultrasound a little bit more frequently in this particular type of care. You can see evidence of effusion. You can see increased blood flow to the area, which can raise your suspicion for potential fracture. You can also kind of trace the cortex of the bone. And if you see an irregularity, again, that might raise your suspicion for getting advanced imaging. So, who knows? But as it is currently taught, these three conditions, SCFE, LCP, like Lennox-Gastaut disease, and transient synovitis, these are typically investigated with X-ray and advanced imaging. But what if that costs $2,000, essentially an ER visit, where it's that expensive, only to just land back into the orthopedist office the very next day? I just don't think that's necessary. I don't think that's value at the end of the day. That is not how I perceive value. For the medical students listening out there, I am trying to reach out to you guys. I would love to give talks at your clubs or do grand rounds, things like that. I think that cases like this need to be brought up at the medical student level when you guys are still really very open to new ideas. And I want to make sure to inspire the next generation so that you guys continue to do the right thing, look at the big picture, come up with other solutions, not just the ways that have been taught to you by your attendings, which is usually an insurance-based answer. And that's just not the way that I think medicine needs to go. So for you medical students out there, I hope you're listening to this. Take this case into account. You know where to find me. Thanks again for listening. Take care.
Thank you for listening to the Talking Rehab podcast.
I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.